we'll just go ahead and get started. And as they come in, we'll just keep going.
Okay.
So my name is Charlie Price, and I wanted to thank everyone for coming into our webinar on the effect of anti-doping in research with Dr. Gary Green. For those of you all attending, if you have any questions during the webinar, just go ahead and put them in the chat, and then Dr. Green will either answer them during the presentation or at the end. We can read them off and answer them then. So without further ado, let me introduce Dr. Gary Green. He went to, gotta help me say this, Hahnemann University?
Yeah, Hahnemann is now become Drexel.
Drexel,
yeah.
In Philadelphia. He did his internship residency also in Pennsylvania, at the Pennsylvania College. He's a current medical director for Major League Baseball and the research director for Major League Baseball. He's the MLB consultant on anabolic steroids and performance-enhancing drugs. He's a current clinical professor at UCLA, Division of Sports, and he works with Pacific Palisades Medical Group, Pacific Palisades, California. All right, Dr. Green, it's all yours.
Great, thank you, Charlie, and thank you to the AMSSM and Joan for help facilitating this. Hopefully, all the technical problems are behind us. So, thank you all for coming. And I thought I would just start with a brief introduction of myself before we delve into the topic. One of the things that people always ask me is, how did you become the medical director for Major League Baseball? And obviously, I didn't plan on doing that. And I think that emphasizes that you really don't worry as much about the goal as the journey, because the best thing is really to just do your best at every stage of your career, and then things will fall into place. And especially with respect to sports medicine, a lot of people ask, how do you get in sports medicine? What I would say is, first, you have to be a really good doctor, because the patients don't know that they only have a sports injury, and you have to really be aware of all of medicine. There's lots of cases of people coming in with a supposed sports injury that end up with an osteosarcoma or other bone tumors. I had a case with a woman who was doing aerobic dancing and step aerobics, and she had Achilles pain, which looked initially like Achilles tendonitis, and on working it up, it turned out she had sarcoidosis and Lofgren syndrome, which is a variant of sarcoid that affect the tendons. So, unless you know all of medicine, you really can't be a good sports medicine physician. So the first thing I would say is become the best possible physician you can, and then the sports will come later. And I thought I would just kind of give you a little insight into my career, as what I would say is my career was defined by 4 phone calls. And so I thought I would just briefly tell you about that. The first phone call came the summer before I started medical school. I was on the waiting list for medical school, and late August, and was working at a lab that I had just started work at because I didn't think I was going to get into medical school. And ran into a friend of mine who asked me what was going on with the wait list. And I said, oh, I hadn't heard yet. So she goes, well, they're going to start soon. You should give them a call. So I called up Hahnemann, and I said, when does school start? And they said, tomorrow. And I go, oh, well. And they go, oh, what's your name? And I told them. They go, oh, you're in. We've been trying to reach you. This is obviously before cell phones. And so they said, you're in. So I started medical school the next day. The second phone call I got is, as I was finishing my residency in internal medicine. I did a very straight traditional internal medicine residency, a lot of call, a lot of critical care medicine. And I developed a little sports medicine rotation for myself, because our residency didn't have one, and was looking to get into sports medicine. And at the time, there were only 3 fellowships, 3 positions in the country for primary care sports medicine. I think the field had started the year before, in 1985 or so. And so I was looking, I didn't get a spot because there really weren't very many available, and I had no experience. So a friend of mine happened to see an ad in the Philadelphia Inquirer for a head team physician job at the University of Delaware. So I applied for that, got the job despite having no experience, and all of a sudden found myself responsible for the sports medicine and primary care for 800 Division I AA intercollegiate athletes, with no orthopedist there and just me by myself, seeing about 70 or 80 patients a day, for 2 years, and was really an on-the-job training. And then I was doing that for about 2 years and decided I was trying to do a little bit more research, and was offered an assistant team physician job at Penn State University. But I didn't really want to take it. It wasn't a perfect job at Penn State. So I called Dr. Jim Puffer, who at the time was the UCLA sports medicine primary care director, and asked him what he thought of the Penn State job and if I should take that or if I should wait for something else better to develop. And in the course of the conversation, he said, well, if you're looking to relocate, I need a partner. Would you like to join me? And so that landed me at UCLA for about the past 30 years. And then I also, the next phone call was from Major League Baseball, who, and this will segue into our talk, and they were looking to develop a anti-doping program to address their steroid program in the early 2000s. I almost didn't take the call or take the meeting because at the time Major League Baseball had a really bad reputation, but Rob Manfred, who's now the commissioner of baseball, convinced me that they were very serious about changing the culture of baseball. And so I accepted the job, and over the next 7 years, we were able to significantly change the culture of baseball to the fact that we now have the most strict anti-doping program in professional sports. And then finally, about 7 years ago, Commissioner Manfred called me and asked if I would like to be medical director for Major League Baseball in addition to my work with the drug testing. And I guess they had liked my work that I had done elevating their drug testing program, and now became a medical director for the last 8 years. So none of these things were planned, and it's just being open to opportunities. So with that, let's talk a little bit about the subject tonight. The first is about anti-doping, and I guess the best way to start is I assume you've all had pharmacology, and in basic pharmacology, drugs are grouped according to their class. So for example, all the barbiturates are together, all the anti-inflammatory and NSAIDs are grouped together, benzodiazepines are grouped together. Well, in sports pharmacology, we group drugs according to the reason that the athlete's taking them. And we group them into three basic categories: ergogenic, recreational, and therapeutic. So ergogenic is performance enhancing. So this is what an athlete is taking in order to increase their performance. So an example of that would be a weightlifter who takes anabolic steroids in order to get stronger. There's no therapeutic use. It's just being used for the pure performance. The second category is recreational drugs, and those are things I'm sure you're all familiar with, if not personally, then in practice, with things like marijuana, alcohol, cocaine, opiates, heroin, and those types of things. Athletes are at no greater or lesser risk for addiction than their non-athlete peers. If you look at studies, some studies show that athletes are more likely or less likely, but it's important to know that just because you're healthy and athletic doesn't mean you can't become addicted to substance. And then the third category is therapeutic drugs. And this would be what an athlete takes in order to treat an underlying medical condition for a legitimate medical reason. So why is this important? Well, let's think of a drug like amphetamines. So amphetamines can be used for ergogenic, for performance enhancement. For example, Tour de France riders use it to increase energy to stay alert on their long distance bike rides. Amphetamines can be used in the form of methamphetamine for recreational purposes, or you can use amphetamines for treatment, such as attention deficit hyperactivity disorder. Drugs like Adderall are amphetamine salts. So it's the same drug, but it's used three different ways. And I think you would agree that the approach to an athlete using these drugs in different ways, in each way, would be a different approach. You would approach somebody with a therapeutic use much differently than someone for performance enhancement. And in most cases, recreational drugs are treated as a medical condition with addiction. And therapeutic drugs, every drug testing program will have a medical exemption or what's called a therapeutic use exemption. So for example, there's many drugs on the World Anti-Doping list that are banned, such as insulin is banned. as I said, stimulants are typically banned. And so in order, if an athlete needs to use these, they have to go through a process to demonstrate that they have a legitimate medical indication that they would suffer significant harm if the drug were to be withdrawn, and that there are no non-banned alternatives. So every drug testing program has this in place so that athletes can legitimately use drugs to treat a medical condition. And you could argue, well, isn't this performance enhancing? Well, in some ways, but really what it's doing is it's bringing them up to the level that they would be without that underlying medical condition. So, for example, an asthmatic who needs to use a beta-2 agonist, he's not getting an advantage. What he's being brought up to is where he would be without the asthma. So if you have questions on this, just put this on the chat and we can answer the questions as we go along. Otherwise, we can do them at the end. The category that you're probably most interested in is ergogenic or performance-enhancing drugs. And why do athletes take these? Well, obviously to enhance performance. And the performance increases can be very small. For example, if you think about the 100-meter dash at the Olympics, the difference between the first place finisher and those who don't qualify for the finals is very, very small. And if you had to do a statistical p-value, I'm sure the difference is negligible. For example, there was a gold medal crew race a few years ago at the Olympics where I believe the winning crew won by about 4/100ths of a second. Well, in order to do a study to distinguish whether there's statistical significance between those two boats, you'd need about the population of China as your study subjects. So what can happen is the difference in terms of clinical significance and athletic significance is very different. So we have a question here. With your example of asthma, couldn't you use the same logic to justify an athlete on TRT? Is that testosterone replacement therapy? I think that's okay. So athletes can apply for a therapeutic use exemption for the use of testosterone, but they have to go through and document that they are actually truly testosterone deficient. And in a elite athlete, somebody in their 20s or 30s, testicular failure is exceedingly rare. And we specifically say that you can't be low normal testosterone, but you have to be diagnosed by an endocrinologist, have a underlying medical reason for testicular failure, which is much different than the older population, let's say over 50 or 60, that has low testosterone. So one of the criteria for a testosterone, for any kind of therapeutic use exemption, is that you can't have low normal levels. And the other thing is that the use of the banned drug isn't because you used a banned drug. So for example, somebody who's a chronic anabolic steroid user will probably be testosterone deficient for a significant amount of time, but they would not be allowed to have a therapeutic use exemption because their exemption was on the basis of using a banned drug. So that would disqualify that. So in point of fact, if someone has, let's say, a pituitary tumor, if they have primary testicular failure, yes. Or we actually, when I was with the NCAA, we did grant a testosterone use because it turned out that the athlete had Klinefelter syndrome, and so was not making any enough natural testosterone, and so he had been using it since puberty. So that was approved. But in general, those are pretty rare. So so Ryan, thank you. That's a great segue into the next topic, which will be anabolic steroids. So the first thing is, what are anabolic steroids? Well, the first thing I would say is don't use the term steroids, because steroids is just, as you remember from pharmacology, just a broad class of four-membered ring structures. So for example, estrogen is a steroid. Vitamin D in milk is a steroid. Many of the hormones that we have, in addition to testosterone, are all steroids. But when we talk about these drugs, what we're talking about is anabolic androgenic steroids. And the name is important because all these drugs have both androgenic and anabolic capabilities. So what's an androgen? An androgen is something that creates male secondary sex characteristics. It creates male pattern hair growth, and all the things that go along with being male. So all the secondary sex characteristics. The anabolic part of the equation, anabolic means building up of the body substance or protein building. So it's important to know this because it's the anabolic effects that are responsible for what athletes are taking it, but it's the androgens, the androgenic effects that are responsible for most of the adverse effects. And all of these drugs can affect all of the parts of the body. So let's talk about the anabolic effects first. So all these drugs athletes take in order to build up body muscle. And are they effective? Do they work? Well, if we were giving this talk in the 1960s, I would be saying, nope, they don't work. All the studies show that anabolic steroids don't increase muscle mass. They don't do anything. Well, the reason for that was the studies that were done initially used replacement doses of testosterone. So, for example, the average male makes about 10 milligrams of testosterone a day, the average woman about a tenth of that. So if you give a male the equivalent of 10 milligrams of testosterone a day, all you're going to do is shut off the natural production from the testicles and replace it with store-bought testosterone. So you're really not going to get any advantage. In addition, the early studies used untrained individuals. So I assume that some of you out there in the audience have done weightlifting. So what happens when you've never weightlifted before and all of a sudden you start lifting? What happens in the first few weeks for the amount of weight you can lift? Well, it goes up dramatically, okay? Versus if you've been lifting for many years, you probably don't increase very much because you're at pretty much steady state. Yeah, so Ryan writes in newbie gains. It's exactly, that's a good term for that. So what they did is in these early experiments, they used replacement doses and they used untrained individuals. And what happened was both groups improved dramatically. So they said, you see that? There's no difference in anabolic steroids and they don't work. And that's what we told athletes really up until the 80s. And it wasn't until the late 80s or that Dr. Shelley Basheen, what he did was he took trained individuals, gave them 3 times the physiologic dose of testosterone, and he did CAT scans of their muscles. And what he found was that using these high-dose anabolic steroids combined with a high-protein diet and working out vigorously, you could build muscle compared to placebo. So that was the first time that this had ever been done. But do you think that the athletes were really waiting for Dr. Basheen to publish his study? No, they were doing other experiments on their own. So for example, the East Germans, we know now from declassified East German secret police records that the East Germans were engaging in very high dose anabolic steroids for their athletes, especially their women athletes. So if you look at the East German women's swimming team in 1972, they had no gold or silver, no gold medals, no Olympic records. 4 years later, they set 10 out of 11. They won 10 out of 11 gold medals, and they set 10 Olympic or world records in just a 4-year span of time. And then you fast forward to 1992 when the two Germanys were reunited. And you had both teams together. They won, I think, 1 gold medal and no world records. And they basically were back to where they were in 1972. And we know now that they had started their program of increasing anabolic steroid use in their female athletes. So athletes certainly knew that they worked, but it wasn't really until scientifically that it was proven to work. So what are they? So we know that they work. What are the adverse effects? Well, the adverse effects really depend on the amount of natural testosterone that you produce. So if you're a man, a grown man, grown woman, or a developing adolescent. But there are some things that go with all of them. So for example, for the cardiovascular system, anabolic steroids will lower your HDL or good cholesterol. They'll raise your total cholesterol, raise blood pressure, increase sodium retention, and basically will be a setup for heart disease. So I've reviewed probably hundreds, if not thousands of records from some of these anti-aging clinics who are giving, as part of police raids and DEA raids. I've reviewed patient records from some of these doctors who are legally prescribing anabolic steroids. And you probably know that normal HDL cholesterols are probably 40 or 50. And most of my patients want to have as high of HDLs as possible, or good cholesterol. Well, in several of these cases that I reviewed, people had HDLs in the single digits. So like I've seen HDLs as low as 7 or 8. And there have been reports, and case reports of bodybuilders in their early 20s having heart attacks. There's been several that needed heart transplants as a result of cardiomyopathy and atherosclerotic heart disease. So from the cardiovascular standpoint, these can be very damaging. For the GI tract, if you're taking these drugs orally, they undergo first pass through the liver, and you can get transaminitis, hepatocellular carcinomas, and a rare condition called paleosis hepatis, where you get the formation of blood-pooled cysts in the liver. Fortunately, many of these are reversible when the when the person stops taking them. For males, the other thing that can affect everyone is tendon injuries. So even though you're strengthening the muscles, the tendons don't get correspondingly strengthened. So you'll have a lot of muscle tendon injuries, and not just the normal strains like you see with like a hamstring or quad strains or even Achilles. You'll get I've seen psoas muscle strains, pectoralis major strains, triceps tears, pec major tears. So areas that you don't usually see in sports. Not to say that everybody that has one of these injuries is using anabolic steroids, but it just raises a little bit of a level of suspicion. The other things depending on your hormonal levels. So for example, males will get lots of different effects. By giving high doses of anabolic steroids, a couple things happen. One is the testicles will shrink. A lot of these guys will have the testicles shrink down to the size of peanuts or raisins. A lot of this can be often irreversible. So what happens to these guys is when they come off them, their testosterone levels are very, very low. They feel terrible, and then they go back cycling on. So that can happen. Obviously, things like acne, stria will happen. If you think about all the things that happened when you went through puberty, that can happen. Hair loss and sperm counts will become very, very low to almost zero. So if fertility is an issue, these things are obviously very detrimental. Women get the viral. The other thing that men can get, if they're taking such high doses to give super physiologic doses, that oftentimes the liver gets overwhelmed. And so what the liver does is start converting this to the estrogen pathway. And that's not a good look in a man. So they'll start to get gynecomastia, breast growth. And so there's actually a lot of these people will take estrogen blockers like tamoxifen or anastrozole in order to block the estrogen effects and drive more of it towards the androgen side of the metabolism. So a lot of these will get aromatized to estrogens, which again, not a good look in males. The other thing in women, they'll get the virilizing effects. So they will get male pattern alopecia, acne, Adam's apple in the throat, the loss of breast tissue, menstrual irregularities, deepening of the voice, and clitoromegaly. And deepening of the voice and clitoromegaly are often irreversible. And so a lot of these things in women are particularly damaging. Some of the East German women had to go and live like decided to become men because they had lost so much of their female characteristics that it was just easier to live as men. The other thing in women that we see with the East Germans, women who were part of this program, is they had severe birth defects in their offspring, about 10 times higher than the normal German population. Not only their offspring, but now we're seeing it in their offspring as well, so in the grandchildren of these women. So very, very devastating types of things. The other things we can see in adolescents who are still growing is premature closure of the epiphysis, psychologic problems in this. We've had several adolescents who have committed suicide while coming off this. So adolescents seem to be particularly vulnerable. And in terms of talking about the psychologic aspects, you've heard of things like roid rage that happen, and addiction. There's been some debate as to whether these things are truly addictive. I can tell you that in my experience, there are people who do meet the DSM-4 criteria for addiction, and that people who would like to quit but can't. And what happens is they get addicted to the look. So we talk about. Sorry, my dog is just chewing on stuff here. We have a puppy here. Roxy, stop. Sorry about that. So we have people who really become addicted who can't stop using. And what happens is they become addicted to the look. So whereas you've probably all heard of bulimia and anorexia, where the anorexic girls who look in the mirror and they may weigh like 90 pounds, but they think they look fat. Well, they get what's called, the anabolic steroid users get what's called the Adonis complex, where these guys are huge and they look like they've been blown up with an air hose, but they think they look small. And so they'll go to the gym and they'll think that they look in the mirror and they think that they look small. And these are guys who are just absolutely huge. And so they get addicted to that look. Plus, they get addicted to the aggressiveness that goes with anabolic steroid use. So the psychological aspects can be really bad. And as I mentioned before, we've had people who really do want to get off them. And when they try to cycle off, what happens is they get very depressed because their testosterone levels are low. And especially these bodybuilders who have been using injectable anabolic steroids that have a very, very long half-life. For example, in drug testing, if you inject nandrolone as an ester, as an oil base, we've been able to detect it with drug testing for up to 14 months or more. So these things are very long-acting, and the suppression on the pituitary gonadal axis can be long-standing. So these are things that that really are significant with that. So for drug testing, what we do is one of the things to tell you briefly about drug testing is drug testing is a constant cat and mouse game, in that every time you build a better mousetrap, the mice get a little smarter. So we started in the late 80s. We developed what's called gas chromatography mass spectrometry, and that's very good at detecting foreign or exogenous anabolic steroids. So things like nandrolone, stanozolol, methanedienone, dianabol. The testing became very, very good for these drugs. So what did athletes do? Well, they switched to shorter acting drugs, and that have, instead of using injectable, they started using orally based oral ones, which have a shorter half-life. And then we got better at detecting some of the metabolites of these oral agents. So then athletes started going to use testosterone, which is obviously a natural compound and harder to detect. So what we developed was what's called the testosterone to epitestosterone ratio. So it turns out that for every molecule of testosterone that you produce a molecule of epitestosterone, which is not bioactive. It doesn't really have any biologic purpose, but it's a really nice marker. So what happens is, if you take testosterone, you will increase your testosterone, and you'll suppress your production of epitestosterone. So your TE ratio, which is usually about 1:1, will go up. And if you get to be over 4 or 5:1, it's evidence of testosterone use. We've also developed something called carbon isotope ratio mass spectrometry. It's also called carbon isotope ratio, in which we can measure the carbon in steroids in your body. And depending on the ratio where it comes from, we can tell with very good certainty that someone has used exogenous testosterone. So I'm going to change a little bit of fields to talking about baseball and the effect of research on changing sports. Any questions before we move on drug testing? I guess the only thing else I would say about this is, how do you change a culture? So for those of you who are sports fans, you may know that in the 80s and 90s, Major League Baseball had quite an anabolic steroid problem. There was no testing, and players, it was thought that, again, just like it was thought that anabolic steroids didn't work, it was thought that anabolic steroids wouldn't help a baseball player, that being muscular wouldn't help you. And in fact, baseball players often did not engage in weightlifting. They didn't engage in weightlifting because they didn't think it would help. And what happened was, it turns out, Sorry, my dog is just underneath my feet here. It turns out that it does help. And if you can hit a baseball farther, it helps. So in the last 10 years ago, we had the Mitchell report, which outlined what had happened in baseball and steps forward. And fortunately, baseball has now come a long way, and we have the strictest anti-doping program. We were the first sport to do blood testing for human growth hormone. We do out-of-competition testing. We do thousands of tests in competition. Plus, we started testing at the minor league level. So at the minor league level, the penalties are pretty severe, and the penalties have increased at one point. So I had a question here from Jesse. What is the most common positive drug test in MLB now? In the minor leagues, the most common one we see are probably the class of anabolic steroids. A lot of those, we still have athletes that potentially take that. However, the percent positive rate is probably under 1%. So it's a very low rate. At the major league level, we do still see anabolic steroids being tested. There also are more, we also do see marijuana tests, but those are referred for what we call the clinical track, where they're referred for treatment, and they aren't suspended unless they failed their treatment program. I can't really talk about, Marcus asked a question about Robinson Cano, he must be a Mariners fan, about the suspension for furosemide. So furosemide is also known as Lasix, is a loop diuretic, and loop diuretics are banned under almost all drug testing programs, including Major League Baseball, the World Anti-Doping Agency, and most others. And the reason for that is not that furosemide would give you a competitive advantage, but that it can mask other drugs. So what happens is, if you take a diuretic, you dilute your urine, and and then you can, hopefully, if you're trying to take this, you'll be below the threshold for that particular drug that you're taking, because most drugs have a drug testing have a detection limit. So you hope that you get under the detection limit. And athletes will go to very creative ways to avoid a positive drug test. As you can see with Major League Baseball, the penalties are quite severe for testing positive. So unfortunately for these athletes, these diuretics are very readily detectable, and so people can be suspended for using a diuretic. And Ryan also asked about the StarCast controversy in the NFL. Dietary supplements, and we could talk about this for a long time. Dietary supplements are a very difficult subject. Because of the Dietary Supplement Health Education Act of 1994, also called DSHEA, it basically was a license for supplement companies to do whatever they wanted. If you think about it, in order for a pharmaceutical to get to market, you have to go through basic research, animal testing, phase 1, 2, and 3 human testing, and then only after that can it be put on the market. Dietary supplements are the exact opposite. You can put whatever you want out there as a dietary supplement, and then if it kills people or hurts people, well, then maybe it can be taken off the market. So there's very poor quality control. In fact, I did a study about several years ago where we took 12 supposed muscle building supplements and tested them in our lab at the UCLA Olympic lab, and 11 out of the 12 did not contain what was on the label. They either had more than they were supposed to have, less than they were supposed to have. They had ingredients that weren't on the label. They had ingredients that were on the label that weren't actually in the pills. We also found significant variations from pill to pill. So the message to our players has been, unless you know exactly what's in your supplement, you're responsible for what's in your body. And that's the hallmark of almost every drug testing program, that doesn't matter how it got into your system. If it gets into your system and it's proved that it's your urine or blood sample, you're guilty. Unless there are major extenuating circumstances, which are very, very rare. So, athletes will often say, well, I took a supplement, I just went to the GNC. Well, we don't accept that anymore. And there's something called NSF for Sport, which you can look up. They also have a app. It's called NSF for Sport. And they currently, through our work with Major League Baseball, they certify over 700 products. It doesn't say that these products are are good for you or that they have any kind of benefit. What it says is the NSF certifies that what's on the label is actually what's in the product, and that you will not test positive as a result of, using those products. And since we started doing that, we haven't had any players claim a supplement as their result for a positive. Charlie asks, what other medications like diuretics are being used? Those are the main ones. It's diuretics that are being used. People often try and dilute their urine. The other thing that people have done is go through very clever ways of trying to mask a positive drug use. There was something, if you want to Google it, called the Wizinator that was out a few years ago, which was an artificial penis and a bladder that you could put in your shorts, and then you could simulate urination, and you could put somebody else's urine in there. Unfortunately, that doesn't work for professional sports testing or Olympic testing, because in like MLB testing, you have to disrobe from your basically the strike zone, so from your chest to your knees. So that would be easily detectable. The other thing that people will do is there have been cases of people, believe it or not, self-catheterizing. So they put a catheter into their bladder, drain their urine out, and then pour someone else's urine into their bladder, which has caused some pretty nasty urinary tract infections. There was also a couple Olympic weightlifters from Bulgaria in the Athens Olympics who took a rubber ball, basically a small rubber, like a bulb syringe, filled it with someone else's urine, put it into their rectum, and then put some tubing under their perineum, under the underside of their penis with a little bit of a spring load. And then when it was time to give a sample, they hit the spring, and someone else's urine came out. Unfortunately, this was detected by the drug testing collectors and pulled out of the people, and they both lost their gold medals on that. Ryan asked another question about SARMs, which are basically our androgen receptor modulators. There's very effective means for this, and we've actually tested several people at both the minors and the majors using SARMs. In fact, we had some of the Major League Baseball, we reported some of the first uses of SARMs that we were able to detect. So a lot of athletes think that we can't detect these, and they have been wrong. And so we are seeing a lot of SARMs that are detected. And again, it's a game of cat and mouse, that every time you build a better mousetrap, the mice get smarter. So we started having better testing for anabolic steroids, and athletes started using SARMs, despite the fact that none of the SARMs are approved for human use. And you're still seeing people use these. Can be quite dangerous in terms of some of the side effects that they can use as well. All right, so let me talk, we'll have a little bit more time. Let's talk, and if there's more questions, I'm happy to go back. So let me just talk about concussions, because that's a hot topic in football, and obviously most of you have seen the movie Concussion and read about it in the not only the medical literature, but also in the lay press. And unfortunately, there's a lot of misinformation that's done with that. So baseball, fortunately, does not have a lot of concussions. In fact, if you look at sports at all levels, at like high school and college levels, baseball has one of the lowest rates of concussions of any sport. I think it's even below high school cheerleading in some studies that I've seen. So it does happen, and when it does happen, it can obviously be very damaging. But it's not a high. It's not certainly like things like American football. For example, in the major leagues every year we have about 20 to 30 concussions, and that's out of about 1,200 players among 30 teams with thousands of games, with 162 games per team. So it's well over 2,000 games, and we have about 20 to 25. So it happens about once every 200 about once every 200 games in the major leagues, a little bit more in the minor leagues. So one of the ways that we look at concussions, and in fact, one of the things that you may have heard about is called sports epidemiology. So what sports epidemiology is, how do we have a denominator for sports injuries? So we typically use what's called athlete exposure. So 100 athlete exposures would be 10 athletes playing 10 games. It could be 100 athletes playing one game, or any combination of that. So, for example, for concussions in baseball, and I published a paper on this a couple years ago in, I think it was in the American Journal of Sports Medicine. The rate of concussions is about in Major League Baseball is about 0.25 per thousand athlete exposures. It's about 0.4 in the minor leagues. So pretty close but very, very small. If you look at some football data, it's about 18 per thousand athlete exposures. So you can see that baseball is very, very low. So one of the things that we found from our research from this paper that I did, and we looked at all of, the nice thing is we now have a injury reporting system and an electronic medical record for all of minor and Major League Baseball. So it's about 7,500 minor league players, about 1,200 Major League players. So it gives us hundreds of thousands of athlete exposures per year. And what we found was with concussions that among defensive concussions, so these are concussions that happen with players in the field, that catchers had about 40% of the concussions of the fielding players. So if you know baseball, you know that catchers are 1/9 of the fielders. So they should be 1/9 of the, or about 11% of the concussions, but they were actually 40%. So it's pretty clear to anybody that watches baseball that catchers are going to be at more risk. So then we drilled down a little bit to look at those defensive concussions in catchers, and we found that about 40% of them occurred from home plate collisions. And so what we did was, in looking at this, we started a rule in 2014 that limited home plate collisions. So what we did is that the runner trying to score from third has to make an effort to avoid the catcher and to try to slide, touch home plate. At the same time, the catcher was not allowed to block the plate without the ball. And so we put this, and there was a lot of controversy about this. Pete Rose said that we were trying to put dresses on people and that it would ruin the game. But in fact, it has not ruined the game, and it has been within the spirit of the game. And what's happened since then is, since we passed the rule, there have been no concussions due to home plate collisions in the major leagues. And the minor leagues have, I think, reduced it by about 70 or 80%. And the number of home plate injuries has also decreased by about 80%. And these were significant, about the p-value of about 0.001 or less. So a very significant reduction. And just show, I use that as an example as how sports medicine, through good research, can affect the game in a positive way without interfering with the spirit of the game, and still allowing the integrity of the game to move forward. And you'll see some research is not done as well. It's more anecdotal, but it's really important to do good research in this regard in order to solve a problem and make it safer. Since that time, we've also changed the rules on second base collisions, and that's had a dramatic increase. I don't know if someone would want to ask about pitchers, but one of the things I've always been concerned about as medical director is catastrophic injuries. And so the one position that's really at risk for catastrophic injuries is the pitcher, because as the pitcher releases the ball, he's about 60 feet away from home plate, and the ball is coming back at about anywhere from 90 to 100 miles an hour, and they have about 0.3 seconds to react, and they're in a very vulnerable position. And we've had several cases of epidural hematomas among pitchers. Fortunately, all have survived. So one of the things I started a few years ago was developing a cap for pitchers to wear. We had several companies to develop something that was lightweight and still not too intrusive on the pitchers. So actually, you know what? I'm going to run get you one, and I'll be right back. So talk amongst yourself. I'll be right back. Okay, sorry about that. I should have brought that with me. So here's a regular baseball cap. Okay, regular, typical baseball cap. And so we developed this to wear. And here is the prototype. So you can see that it's a little bulkier than the normal cap. We only got one player to wear it, Alex Torres of the San Diego Padres. He wore it. He took a lot of kidding. He was called Super Mario, among other things. And surprisingly, this cap did not catch on. And the cap went to the Hall of Fame, believe it or not. Alex, unfortunately, did not, but his cap is in the Hall of Fame. And so we started other prototypes. We now have tried some carbon fiber ones that are very lightweight, but unfortunately, again, the pitchers have not really embraced these. So we're still trying to work on these. We're working with the players, but I think we're going to have to start at the youth level and get them used to it. Pitchers tend to be very superstitious and not really willing to try new things later in their careers. And there's also a little bit of a macho feeling about not wanting to look like you're afraid or that you're worrying about that. And so the pitchers are very much at risk for this, and we're still working to try to reduce that. And I don't know. Charlie said that he was a pitcher in high school, so I don't know if he would have worn it, but we can see what he says on that. Ryan writes, we had a question about a pitcher with commotio cordis on their boards. The pitchers are typically the position in young kids who get commotio cordis. And for those of you who don't know, commotio cordis is when you get struck during the recovery phase on the EKG, so just at the end of the T wave, and it can trigger a fatal arrhythmia. It's often very difficult, if not impossible, to revive the person. There have been some things in Little League for players to wear chest protectors for the pitchers. Unfortunately, what the study showed was that that it often concentrated the forces instead of dissipating them. We actually had a pitcher, we actually had a batter in the Milwaukee Brewers organization last year who got hit on the left side of the ribs, and he went into commotio cordis. And although he lived, he was severely damaged during that time. So it's not just the pitchers. You can also see it in the batters, which again is much more unusual, getting hit on the side than usually getting hit right in the front. Jonathan writes, was there any suggestion given to batters this year regarding the check chin guard? Yeah, that's up to the individual players to wear. Again, that's not going to prevent a concussion. More likely, it's more likely to prevent a jaw fracture or facial fractures, which again are very serious, but not brain injuries. Jesse says, I treat a lot of minor league guys and some of them with concussions because they are so athletic. Any recommendations about balance testing to catch their symptoms? Yeah, I was part of I went every 3 or 4 years, there's a international consensus conference on concussion. And I was part of the last one in Berlin, which the SCAT-5 came out of. And the SCAT-5 is the sideline concussion assessment test. As part of that, there is a balance error testing on that. And so some people, like the NCAA, recommends doing balance error testing as a baseline, and then being able to compare it. The balance testing is a little difficult because you have to make sure it's done on the same surface every time, that they shouldn't be wearing cleats, they should be wearing flat-footed or the same things that they're doing. Balance testing, again, is probably still the most sensitive way to detect concussions is with the symptom score. The SCAT test has a 22 symptom score that's pretty universally accepted. Again, one of the problems is you have to depend on the athlete to be honest about their symptoms. But with all the awareness of concussion, we're seeing better compliance with that. The other thing, there was a nice study that came out recently that showed that the sooner athletes admit their symptoms, the sooner they can return to play. So that's another good way to induce athletes to be honest about their symptom checklist. The other thing that we use is neuropsychologic tests. There's a test, there's many of them that are on the market. One of them is called the impact testing from the University of Pittsburgh. And for all of most NCAA colleges, as well as minor and Major League Baseball, we require them to have a baseline testing before the season, and then to compare that. The impact is a proprietary test, and it does cost money to each school that's going to be using it, but they also get the benefit of evaluation. And it's become some sort of neuropsych test, and again, there's different ones that are available. It does become somewhat about liability at certain levels as well. Anything else about concussions? Concussions are obviously something we could talk about a long way. So I'll end this by just giving you a couple of my suggestions for your career. Just something that you might a couple like 7 points to consider. The first one is the theme is oftentimes people think it's your weaknesses, it's your Achilles heel that does you in. And in fact, I can reflect back on my years of practice, it's actually your strengths that are actually more dangerous to people. And if you think about this, came a lot, I've done a lot of work with addiction medicine. And if you think about an alcoholic, okay, think about somebody who you see who's an end-stage alcoholic. How did they get there? Well, it could start from somebody who they go to a party, they're socially awkward, they drink, they have a good time, and they feel relaxed and everything is fine. And so first 10 times they drink, they have a good experience. Then they drink too much and they have one bad experience. But they rationalize it by saying that it was just that they made a bad decision on something. And eventually what happens is the alcohol is how they deal with stress. So it becomes their strength. It becomes that they, it's a coping mechanism. And in most of the time it works pretty well. They go in a party, they have a good time, and things work out well. But eventually what can happen is if that's your only coping strategy, eventually it starts to fail. And what happens is now instead of 10 out of 10 times it being a good experience, it becomes only 8 out of 10, then 2 out of 10, and then 1 out of 10. But a behavior that has positive reinforcement is part of probably the hardest behavior to extinguish. You've probably seen the studies of the rat who hits the button, it gets cocaine, and then they only get cocaine once every 10 times, then once every 100, then once every 1,000. And their paws will bleed because they're still trying to get it, even that 1 of 1,000. And you think, well, that doesn't really apply to people's strengths. Well, the other kind of patients we see is sometimes I see patients who are hard workers. So, and especially people who are professionals like medical students and doctors. And their response to everything is to work harder. So if they have more to study, they just work harder. Well, that's a good strategy at the beginning, and it gives you lots of positive reinforcement because you get promotions, you might get promotions, you get advancement, you get more grants. But eventually, if your response to everything is to work harder, then eventually there's a point where you can't work any harder, and eventually that will fail. And I see that a lot in my practice where people who are very hard driving executives, and now they can't work any harder and they don't know what else to do. So it's really important to know when to work harder and sometimes when to back off. And one of the things that you can do with that is earlier in your career, it's important to say yes to everything. So you want to be the person at the beginning who, if something needs to be done, they can call on you. Later in your career, you need to be more selective about what things you accept. The other thing that this leads to is how do you deal with stress? Because you're going to have stress in your life. The only 2 ways I've ever found to deal with stress, one is to completely eliminate it from your life, move to a desert island and get rid of it completely. The other is to find better ways of coping with it. And so to the degree that you can find ways to cope with stress and have multiple tools in kind of your tool chest, that's going to serve you better. The other thing that really is going to help is in terms of prioritizing. The electronic media has made it much harder as humans because we're programmed to respond to stimuli. That's why humans have prospered as a species, because we respond to stimuli. You hear a growl of a tiger and you run. You respond all the time. Well, that's great, except when we're getting constant stimuli and our adrenaline levels are constantly high, that's probably not a good thing. And so you have to know when to go fast and when to go slow. And one example of that is if you clean out your desk, you find things that you ignored, and now they've just kind of taken care of themselves. So it's really important, especially when you're an intern or a resident, to prioritize and figure out what needs to be done immediately and what can wait. And if you can do that, that's going to really help you for the rest of your career. The other thing is, don't be afraid to stick to your principles. You don't want to be hardline about it, but you want to make sure that you have your principles and you stick to them. I'll just give you an example of that. I had a medical student who came to see patients with me in my office, and he showed up with long unkempt hair, a plaid shirt, ripped jeans. And I said, "What are you doing here?" He goes, "Oh, I'm here to see patients with you." And I said, "No, not dressed like that." And I said, my patients have a way that they like the doctor to look, and that we need to be respectful of the patients. So he went home, came back the next week, and he had his hair tied back in a neat ponytail, had a shirt and tie, and he turned out to be a great medical student, and he became a really good doctor. And so it's really important to be able to, if you do have principles, that you should really stick to them. If you think things are really important. Again, not to be too hardline about it, but like I'll give you another example. I had an undergraduate who wanted to come see patients with me in my office. And even though we don't usually allow undergraduates, we made an exception for him. And he came in, and so he set everything up, and I had everything arranged for him. And 15 minutes go by when he's supposed to come, didn't show up. And I finally called him, and he said, "Oh yeah, something came up and I kind of flaked out, and I'll come another time." And I said, no, you really won't. This was your opportunity. We went out of our way for this. And I felt like I was being really like a hard line about this, but I thought it was a good teaching moment. Well, a few months later, I got an email from this kid, and who said that he thanked me because it was a wake-up call, and he realized that he was being really kind of self-centered, and he's now rededicated his career to becoming a pre-med and going into medicine. And so it actually ended up that he was really appreciative of that. The last thing I'll just tell you is you're only as good as your last patient. I've been really lucky to achieve a lot more than I ever expected in medicine, and have gotten a lot of recognition in terms of media and publishing papers and research and things. But I call those things ego tickles. They feel really good. You can tell your family about them, share them with your friends. It's exciting, but it really is just kind of like a tickle. And the most important thing is what happens when you're in the room with your patient. When you're with a patient, they don't care that you've published so many papers, and they don't care if you've been on TV or whatever you do, or you're the medical director for professional sports. What they care about is the care you're giving at that moment. And if you don't give them the best possible care you can, none of that stuff matters. And so it's really, really important. And that's why, even though I have a lot of other administrative responsibilities, I still see patients 3 days a week, because it really is important to keep you grounded and keep you focused on what's really important, and making sure that each patient gets the best of all of your attention and the best that you can do. So I think we're about out of time. Any last questions? And I hope you learned a little something. I hope this was useful, at least for something. So thank you, Charlie. And Charlie, can I give you one of these helmets, or would you wear one of these or not?
If you had asked me back in high school, I might have said no, but I'd probably wear it now.
Okay. All right.
Well, Dr. Green, thank you so much for coming and talking with us. We can't say thank you enough. And thank you for everyone else for tuning in. This will go up on our website on Monday.
All right. Well, good luck to everybody with your careers, and feel free if you ever need advice or anything, or you wanted to do that. I'm happy to get in contact with you. Thank you. Thank you, Charlie.
Thank you.